As Africa, we have built a body of knowledge. We have best practices to tell the world. And therefore, the role of Africa at the global level is to share our experience as experts in our own endeavors in how we manage the COVID-19. As time goes on, and if African systems, we begin to build resilient systems, then we can talk both financially and also expert-wise. Another area that I think that we've been able to, we bring to the global table is the fact that we can lead our own efforts and be successful with them. So it means that when we sit at the table, we sit as equal partners to look at partnership, collaboration for best practices to pandemic management, but not as recipients of knowledge from the West in order that we can improve our lot. This time we can say we did it.
You're listening to Patterns and Meaning, a podcast by Seed Global Health. We find meaning in patterns, connect history to the present, and illuminate the way forward in global health. I am your host, Edem Tokunu. Dr. Jemima Dennis-Antwi is a multi-skilled midwife and nurse with over 31 years' experience in Ghana and around the world. She led efforts to establish the Ghana College of Nurses and Midwives, a specialist postgraduate fellowship college, and served as its first president and first acting rector, where she led the establishment of 10 postgraduate programs over 6 years. She is a fellow of the West Africa College of Nurses and Midwives and a fellow of the Ghana College of Nurses and Midwives. Dr. Dennis-Antwi is currently the President and Chief Executive Officer for the Center for Health Development and Research. Her long-standing interests include sustaining health workforce education, preceptorship, sickle cell disease, health promotion, qualitative research, and strategic planning and implementation systems in maternal health and midwifery. Her current research work is on sustaining midwifery education during this COVID-19 pandemic and beyond, and this is a WHO Geneva assignment. Welcome to Patterns and Meaning, Dr. Jemima.
Thank you very much.
I'm very excited to have you as a guest since you are my first Ghanaian guest. I've spoken with people from Malawi, Uganda, Kenya, Nigeria, but no Ghanaian yet. So,
wow, that is very interesting. It's my pleasure to have the opportunity to be interviewed by you.
Thank you. Thank you so much. So we can start off with just a little about yourself and a bit of your background.
I am a nurse and a midwife. I see myself more as a health system strengthening person. I look more into programming and research and strengthening educational systems, and then also implementing programs that will seek to develop professions and then also to have a well-informed population. I've had the opportunity to work globally, having worked with international NGOs and then also with the UN to look at how do we position systems in such a way that we can best achieve. I have publications to my credit and I love what I do.
Awesome. So you mentioned health system strengthening, and for a first question for you is that COVID-19 has underscored the importance of strengthening health systems. From your perspective, what are the components of a resilient health system?
Great. Yes, in terms of health system, when we talk of health system, we are looking at organizations, we are looking at people, we are looking at the activities or the actions that bring together to promote, restore, and then maintain health. So these three sides of the equation brings what we call a health system. Now, if we are looking at a resilient health system, what do we mean? Basically, we are looking at 6 main building blocks to a resilient health system. We're looking at a good health service. You want to make sure that when you go into the health facility, you get what you actually have to have in order to sustain your health or to keep you healthy. You also want to make sure that you are being taken care of by a well-performing health workforce. People who have been trained to do what they must do at the right time, with the right intentions for the right purpose, and also using the right tools and also resources. You also want to look at equitable access. If I'm staying at a very remote community, would my access to healthcare be comparable to the person who is living in the city? So we want to look at equitable access to healthcare. And then we want to look at health financing. Is the health system structured in such a way that myself and the person living in the city or the rich person can have access to a basic tenet of health care that ensures that my health is promoted, restored, and also maintained at the end of the day? And then, of course, leadership and governance. Are we being governed or led by a reliable leadership that would ensure that all these building blocks come together to make sure that health disease burden is reduced or our risk to health is lowered as much as possible? And it is the interplay among these 6 blocks that ensures that we have a resilient health system.
And what are the investments that we need to make to actually create these systems?
Okay, so again, it comes back to, I would say, these same 6 building blocks. The investment we need to make is, of course, our health workforce. Are we training them based on need? Are we training them and recruiting them in such a way that we can get the best out of them? Are we motivating them so that even if they are posted to the most remote communities, they would go? A lot of times you tend to see more health workforce within the cities more than you will see in the communities, especially the private communities, because of lack of the enabling factors that will allow them to work. And therefore, the number 1 is the health workforce and making sure that they are well positioned and motivated to perform their due services. Another area is looking at the health infrastructure. It's a major issue. Do we have the infrastructures where they should be? And if they are they accessible to the people, or they are built based on political motivations, and therefore you have health facilities that have been planted in certain communities where virtually it's not even accessible? Even if it is accessible, do the health workforce have the enabling environment to work? Do you have people from the community who are prepared to be trained to work there, supposing that you don't have people who will be prepared to be transferred there because of certain social determinants? And then also, are the infrastructure well-resourced so that if I go into the health facility, it's not just a building, but it is a facility that will enable me to have access to the right services? And then another important factor is our preparedness. How prepared are we to deal with epidemics, to deal with pandemics, just like COVID came, where African countries prepared for COVID? So a resilient health system should be tried and tested. The appropriate health workforce, the right infrastructure, a preparedness plan that enables us to act quickly. We must be combat ready with all the resources, people who are well-trained, well-networked, and able to reach out to the people at a point in time in need. And you will realize that Africa, we have not had many epidemics that cut across the entire country. We tend to have pockets of epidemics, so it's more like regional based. A typical example is the Ebola. So we have countries like DRC, Democratic Republic of Congo. We have Sierra Leone, Liberia, Guinea being affected. And therefore, it was like within a certain belt. So most of the time, our preparedness may not be as resilient as we expect it to be. And I think that COVID has, I believe, has taught us lessons that will enable us to become combat ready. Then, of course, the complementary actions of looking at adequate capacity management. If the capacity is there, how are we managing this capacity in order that they are ready and available at a time when we need them? We also want to make sure that how are we enhancing our service delivery system so that we have quality care for our patients, and then our staff are working in a safe environment, and patients can also have access in safe environments. We need to look at health information. What are we doing with the evidence that is so rampant within our community? Do we collect the evidence and put them in reports and stack them? Or we actually look at what the reports, what the data is saying, and therefore building knowledge, or building the knowledge is speaking to us, and we hear what the evidence is telling us and we act accordingly. I think that is one major issue within our system. And then, of course, how do we engage with our stakeholders? How are we bringing communities on board? Remember when the vaccines were coming to Africa, there was a lot of hue and cry because the public will not take it because they believe that these are vaccines that are being sent to sterilize the African population, to reduce our numbers, to bring us disease. So there was a lot of hue and cry. Gradually, through education, people began to receive it. And therefore, we had, for example, in Ghana, over 500,000 people accessing the vaccine within the first phase of its delivery. So community engagement is very critical in making sure that we have resilient systems that can work to the benefit of the people in restoring and maintaining health.
So do you think that, with all these different things that we can invest in and put in place of building a resilient health system, do you think we've actually learned our lessons from the pandemic? Let's use our country Ghana as an example.
I think that generally as a health worker, I would say Ghana has done tremendously well. Right from the political will to mobilization of the health human resource to community compliance, a level of community compliance, especially during the first wave. I mean, you had our president coming forth and almost every week or two addressing the population. And then it moved to monthly, trying to encourage us, trying to support us, and look at the economic relief that we're giving to the average Ghanaian. Look at how deprived communities were accessed with food. Look at how healthcare, every COVID patient was seen at no cost to himself or to the family. Look at how we did community contact tracing to make sure that we can identify all contacts and bring them to be tested. Look at laboratory testing. We made Noguchi Memorial Institute for Medical Research the center of all testing, and how we were able to mobilize technology, looking at the drone system to collect samples from all over the country and bring them to Noguchi to be tested. And it was interesting to see these drones just coming into Noguchi and dropping their bags for them to be picked up, and the result, they're tested and results sent back. I think it showed the power of working together and what it's able to achieve. I would also say that there was a cooperation from the public, because if you look at the swift way within which our country or most African countries acted, there was a swift reaction of locking down all the borders, closing all the borders, locking down a lot of the cities where there was a ban on social gathering. There was also the public request to wear masks, washing of hands, use of sanitizers, and then also insistence on compliance. Because you go into every public building, if you don't have your mask on, if you don't use at least a sanitizer, you're not going to be allowed to go out or go into the building and out. And I think that sort of made people compliant if they want to access public service. Another I think plus to all our effort was the public education, even to the extent that the Minister for Information was there every week mobilizing teams from the Ministry of Health to give updates on how we were performing, what the data is, and how they are tracking it. So I think that everybody was brought on board. Again, religious leaders were consulted, so there was a lot of consultation with religious leaders, asking them to comply with the provision of certain restrictions that were put. And to date, you go to churches and you realize that they are taking down names, the sanitizers, the washing of hands, and social distancing. So I think that was powerful enough to make sure that we were complying with the provisions of prevention. And I think that Ghana, I would say Ghana did well.
So at the beginning of the pandemic, there were a number of predictions about how COVID-19 would actually devastate African countries. But however, across the continent, we've done better than was predicted than countries in the West. So do you think this is going to change who is considered an expert in global health?
This is a very interesting question. And whenever I think about it, I smile. I think that generally the West had the impression that, looking at the fact that as Africa, we had weak infrastructure, we had weak health systems, health access by communities was inequitable, so not everybody had access to good health care. Generally, our nutrition was poor, and then also we had poor infrastructure. Most African countries relied on the West for financial support to build its systems. And therefore, it was expected that when the pandemic came into being and everything was locked down, the West was not traveling, the South was not traveling, and therefore there was nothing like a North-South collaboration. Everybody had to deal with their own problems. And therefore, it was expected that given our system that we had in place, we were not going to survive the pandemic. But another factor was that, again, as I said, we were not used to dealing with pandemics.
Yeah.
We've never really been in a pandemic. If you look at the Southeast or China, they've continually have to deal with epidemics of some sort, like the SARS, avian influenza, and all that. So they had some form of preparedness on their hands. What we could boast of were more of famines and war.
That's not for boasting.
if I may use the word. So that was what was rife in Africa. And therefore, it was believed that when it happened, we were not going to be able to deal with the situation. Interestingly, I think that Africans began to realize that now is the time for us to rise up and deal with our own issues. And therefore, I believe that the actions that African countries took, like the swift closure of all borders, was a big plus in our CAP. We also insisted on the restrictions, social restrictions, no gathering. We made sure that the face mask was worn, especially in public, and all the hand washing procedures that we put in place. That sort of helped African countries to begin to deal with the situation. There's also the theory that it didn't happen the way they expected because Africans probably may have built a level of immunity through common infections, and including respiratory infection, that has given us a level of resilience that has allowed us to be able to, though we have the infection, it is believed that we had the infection, but we were able to build some level of immunity. So most people were asymptomatic, and therefore we had over 80% infectivity, but we were able to sustain ourselves. And therefore, looking at it from that angle, I think that as Africa, we have built a body of knowledge. We have best practices to tell the world. And therefore, the role of Africa at the global level is to share our experience as experts in our own endeavors in how we manage the COVID-19. As time goes on, and if African systems, we begin to build resilient systems, then we can talk both financially and also expert-wise. Another area that I think that we've been able to, we bring to the global table is the fact that we can lead our own efforts and be successful with them. So it means that when we sit at the table, we sit as equal partners to look at partnership, collaboration for best practices to pandemic management, but not as recipients of knowledge from the West in order that we can improve our lot. This time we can say we did it.
Awesome. So you think this is going to impact how our knowledge systems are used and where power sits in the global health?
I think that, yes, we would have shared power and not being at the receiving end. Because when we begin to talk, we are talking from our experiences, what we were able to do, not what the West did for us. And the fact also is that since we have led, we have governed, and we have rolled out, and we've been successful at that. And therefore, we will be sharing our experiences and advising on changing the narrative around maybe managing pandemics going forward in the future. And I think this is an opportunity for us to join in publications so that we can tell our story as it is to inform global health and how to move forward.
So let's talk about human resources for health. Some of our past guests have shared how health professional education in their countries is influenced by colonial and neo-colonial legacies. And this in turn impacts health professionals' ability to address their community's needs. So what has your experience in Ghana and beyond been around this?
Right. And I would say that, yes, I mean, a lot of African countries, by virtue of colonization and new colonization, have had to rely on the West for a lot of our development systems. And if I say so, if you look at the educational system, we used to have infrastructure being very limited. I mean, most of the universities had a certain intake which they couldn't go beyond. Most of our training institutions had few infrastructure, and therefore you could not take that many people in because what the colonial masters provided, we seem not to have gone beyond that. We also had a system whereby if you want to seek higher education, you have to travel abroad because our educational system provided us with the basic. And then there was a high dependency on international consultancies and for them to come and build our systems or to direct us in the way to go. However, when we reflect on the Millennium Development Goals in the early 2000s, and it was realized that there was the need for building a resilient health workforce in Africa to be able to address the very high maternal morbidity and mortality, and also that of infant mortality, it became evident that there was the need to train the human workforce. And therefore, a lot of countries began to look inward to say, how do we raise our health workforce? Believe you me, around the early 2000s, for example, if you take the midwifery profession, it was near extinction. A lot of people were nearing retirement, and there was no plan to replace them. And therefore, there was a sudden realization that if we don't train more midwives, we are going to worsen our maternal mortality statistics. And that meant that there was the need to reformulate policies or to review policies that enabled board training of various cadres of health workforce, and then also training them at a higher level that enabled them to take management decisions or to lead in innovative strategies. So we began seeing expansion in our university. We used to have only 3 universities in Ghana, University of Ghana, University of Science and Technology, and then the third one
Was it Winneba?
was
Cape Coast.
the University of Cape Coast.
Yeah.
But currently, look at what we have now. We have many universities, and even the traditional universities have expanded their intake. As I indicated, if you wanted to seek higher education, you had to rely on scholarship, and then you had to travel abroad to the West in order to access higher education. But through a realization of the need to build a human workforce, now you can even read your PhD in your local countries. A lot of the professions have expanded their intake. They have expanded the level to which you can train. And therefore, it means that we have well-qualified human resource to be able to reach out to the needs of the people. And this, more or less, has helped a lot in making sure that we have moved from the neo-colonial system to be able to build our own workforce. Another thing also that has happened is that as we began to train our own people, there was a need to begin to look at what are the national priorities. What are the gaps in human resource, and therefore what should we be doing? So that gave the opportunity for educational institutions to design their own curricula. They had global standards to guide them. They had local opportunities to conduct gap analysis so that we'll be able to know what the needs are within our country. And then also we had the opportunity to make sure that at the end of the day, our courses are culturally sensitive in order that we can bring on board areas within our own culture that serves to inform the design and the building of competencies for our students or for our health workforce. And I think that this has been very instrumental in having a diversified health workforce that come together as a team in order to deliver our health workforce.
And Dr. Jemima, as the first president of the Ghana College of Nurses and Midwives, how do you ensure that the programs align with the country's health priorities and prepare health professionals to provide care based on their community-specific needs?
Right. So, yes, I had the privilege of being selected as the first foundation president for one of our academic institutions, I would say a professional academic institution looking at specialization. That is the Ghana College of Nurses and Midwives. This is a college that was set up by an act or an instrument of parliament that seeks to look at developing specialist nurses and midwives, again, as part of developing our independence to be able to better care for our own and to move away from the neo-colonialist era where we again dependent on the West for every resources, the human resource that we needed. So based on that, I think that as the foundation president, I had, and then also the first acting rector of the college, I had a responsibility to look at both the administration and then also the academic side of the system. And therefore, there was the need to synergize the development of the administrative system and then also the academic system. But since we are talking about academics, let me focus on the academic area. So basically, I think that to start such a new program, there is the need to identify what exactly is the need area. What specialist programs exactly do we want to develop? And I think that we must always be guided by the fact that when you look for the information, you will find it. So there was the need to look critically at, if we are designing our academic programs, where do we start from? We start from gathering the data as to what are the needs of the healthcare system in terms of providing optimal care for our patients. We also want to look at what exactly are the health policy makers saying? What are the human resource priorities? What is the vision of the Ministry of Health? What is the directive of the Ghana Health Service? And what are the gaps on the field? In what way can we work with the other directorates of health services in order that we can produce a cadre of health workforce that meets the expectation? So it meant that we had to continually engage, do a gap analysis to identify what exactly were our own colleagues as the nurse and midwifery fraternity expecting from such a specialist college. We had to engage with the directorates of health. We had to engage with international partners. We also had to engage with the political within which we were operating. And based on that, we were able to zoom in to, let's say, about 8 programs to start with. With the information that we have gathered, informed by global standards, there was the need to set up an academic board that looks at faculty development, preparing faculty, preparing curricula that will address the needs that we have identified, and then putting in place a system that will roll out the educational programs, graduate our products, and then get the health system to recruit them or absorb them and position them in vantage places where they can offer the services. So basically, this is what goes into starting a new program and making sure that you can meet the needs of the particular, I would say, target group or the political system within which you are working. And I think that if you bring all the players to the decision-making table and with the right consultation and engagement, you are able to drive an initiative that at the end of the day meets the needs of the people.
Sounds fantastic. Have you done this with any other country apart from Ghana since you left the role?
In terms of setting up the system, I would say in Ghana. But I've worked with Sierra Leone where they had started discussions around also starting a similar program. And what I have done is to work with them to share the Ghanaian experience and also to encourage them to invest in developing their faculty. So they brought a team of nurses and midwives from Sierra Leone to undertake some of our courses here in Ghana. In terms of looking at other health system strengthening, not necessarily looking at the Ghana College of Nurses and Midwives, but looking at other health system strengthening activities, I've had the opportunity to work with several African countries in sharing expertise or in consulting for these countries in order that they can also develop policies or put up strategic plans that will serve to direct their health system strengthening around particular areas of health in terms of looking at maternal health, midwifery, nursing, and that kind of thing. And I've spent quite a time in Sierra Leone working with the UN to look at, of course, the Sierra Leone, the experiences of the war, and then the Ebola, and how there was the need to build a formidable midwifery system that would ensure that we can improve on the maternal health indices. Sierra Leone has one of the poorest maternal health indices. And since the wartime to date, there has been remarkable improvement. Though it's still high, there have been quite remarkable improvement, moving from over 1,300 to around 700 per 100,000 live births. So I've had the opportunity to work in more than 10 African countries, working with them to support their health system strengthening activities.
Awesome. So when it comes to the health sector across Africa, many countries rely heavily on donors, and you've mentioned this whilst we've been speaking. And these donors in turn get to set the agenda and priorities for programs. So from your perspective, how does this relationship actually impact the provision of health services in communities and ultimately the national development?
Yes, so I think, again, the issue around donor countries and their influence on what I'll call the have-nots, or African countries where our resources do not match up to being able to take certain decisions and stand up to our resources. I believe that, yes, if you look again at, let's say, the early 2000s when African countries pledged to contribute at least 15% of their annual budgets to improve the health sector in their countries. Again, it was all part of the drive towards the Millennium Development Goals. Now we have the Sustainable Development Goals. And for a lot of the countries, they were expected that they can meet this target. Unfortunately, most of these countries could not release even this 15% for health expenditure. Currently, we are looking at countries like Ghana being able to spend at least a $60 per person per year. By last year, to be able to say that, yes, now we spend about $60 per person on health. We don't know the extent to which this has been achieved. But looking at the early MDGs and the fact that 19 years on, though health expenditure in Africa has gone up, these are largely due to partner funding from international partnerships like Global Fund, which is spending a lot of money in Africa, looking at malaria, looking at TB, HIV/AIDS, and therefore helping us to combat these critical diseases. Surprisingly, so far in Africa, it is reported that just about only 10 countries are able to provide free universal health care. So if we have 54 countries, and out of it only 10 are able to provide free universal health care, you realize that healthcare is still a major problem in Africa. And therefore, if we are looking at turning the tables, where we are in charge of our own situation, we are in charge of our own opportunities and taking them on board and building a resilient health system, we will need to come back to focusing. We need to focus on releasing funds for health systems development. So if we talk again about the 6 building blocks, we need to look at good health services. What must we do to provide a good health service? I think that it is not new information. Everything is out there, what it means to have a good health service. And therefore, we must mean it, go all out to achieve it. We must make sure that our health workforce are trained to have the right competencies, not just knowledge, but the ability to perform, the ability to save, the ability to detect, the ability to research. We need to build our health information systems. We need to use the information and to use it to plan, evaluate, and change the systems as the data suggests in order that we can improve. We need to make sure that the essential logistics and supplies that are needed wherever anybody may be are accessible, so that we are not running out of vaccines that are needed for childhood immunizations. We are not running out of basic essential medications because somebody is in the remote community and not in the city where he can just walk it to a pharmacy and buy, let's say, paracetamol. But wherever they are, the basic essential medications can be got and at a price that they can afford. Because even if you put it at their doorstep and they cannot afford it, it means that healthcare is still not accessible to them. And then a system around healthcare financing, making sure that our insurance systems are more pervasive. And if they are pervasive, are they buying us the basic quality health that we require? Or it is such that because you cannot afford to pay, you are being given subservient services. And I think that this is what Africa needs to look at, so that we can have a quality of care at a cost that is affordable to the entire health system. And then, of course, leadership, sitting down to govern the entire structure in such a way that at the end of the day, people, no matter where they choose to be, can access. And we can have a mentoring system that makes sure that as leadership leave and new leadership come in place, who are well also prepared to take up the leadership role. And I think that if we do this as a cycle, rather than as silos in themselves, then all these blocks will begin to come together to be able to achieve a resilient health system that we expect.
So what are some of the lessons that you can share from your experience as a practitioner, a leader, educator, that can aid in our collective efforts to decolonize global health and build a resilient health system that will truly ensure that everyone has access to high quality care where they are and when they need it?
Okay, so basically global health seeks to look at improving access to healthcare and making sure that everybody, that is equitable distribution of healthcare and services. And therefore, as a health workforce, it is important that in whatever role that we play or we find ourselves playing, we are able to make sure that whoever our clients are, they can access what needs to be accessed in a way that enables them to make the best of the resource that is available to them. So in terms of being who I am and the work that I've done so far, looking at within the African continent and then also my contribution to global health, I would say that if I am mentoring my colleagues and talking about how to develop oneself, I will talk first of all at preparing yourself. Preparing yourself by getting the requisite basic training and then also the highest of the training that you can go as far as you can go. Because that prepares yourself, you and position you to be able to access the opportunities when they come. Again, when the opportunities come, avail yourself to the opportunities. There is nothing that comes by easy. Some of the opportunities come in the form of voluntary service. It's not all the opportunities that you'll be paid for. But through voluntary service, you build a resilient experience that people begin to look for. And when people begin to look for what you have, then it gives you a leverage that allows you to lead or to occupy certain opportunities. I think another experience is also delivering on task or assignment. Your mantra should never be, let me do this anyhow. It should be doing the best that I can and leveraging whatever support, whatever consultation to make sure that whatever you are doing is able to stand or compare to your colleagues from the West, because it is a competitive world. And then also taking initiative, because when you are plunged into leadership position, you need to take initiative because you cannot sit and watch the status quo. If you are leading a people, your people must see you as being able to address challenges and to make the needed inroads to be able to change situation. So initiative is very critical as a leader. And then mentoring and being mentored. We live in a system where you never finish learning. And every learning is never wasted. Every learning that you come across come together to make who you are and to open the doors for you. So there's nothing like this is a useless experience. And as you mentor and be mentored, because at any point in time, when you meet within a certain milieu, you are going to meet people who are higher than you, and people who are lower than you in terms of experience and exposure. So you need to avail yourself to more learning from those who are higher than you in the ladder, and also to be able to share your experience with those who are lower than you in the ladder, so that with the interconnectivity of being mentored and mentoring, further builds you up and also prepare a people to take after you. And therefore, you need to continually position yourself in such a manner. And then also recognizing and building strong leadership and empowering people to deliver on their mandate. Empowerment comes again by creating enabling opportunities for people to work. Without these, people can have a strong leadership skill, but if they are not allowed to create, it becomes difficult for them to achieve. Then the last I would say is advocacy, partnership, and networks. You cannot do it alone. When you network, when you build partnership, it's a shared experience. You bring the North-South collaboration to be able to share experiences and to build a body of knowledge. You do South-South collaboration in order that you can strengthen the African continent and you can have comparable experiences. And I believe that through the ages now, it is possible for you to identify expertise in the African continent rather than always relying on a North-South collaboration. So I think that over time, Africans we have African experts. If we create the enabling environment, if we work with them and give them the opportunities, and if we also take the opportunities as they are made available to us, we can gradually build a stronger health system that can ensure improved health, reduce the disease burden, and also make sure that we maintain our health and we can have a beautiful healthcare system in place in Africa.
Oh, thank you so much, Dr. Jemima. That's a fantastic note to end on. And I think even your last words, we're able to apply them not just in healthcare, every aspect of life, like taking initiative, preparing yourself, availing yourself for opportunities. It goes for any profession or industry. Thank you very much.
You're most welcome. You're most welcome. Thank you very much. It's a pleasure to have had the opportunity to share my experiences with you. Thank you.
Thank you too. I thoroughly enjoyed my conversation with Dr. Jemima. My two biggest takeaways were that you need to use the information that is collected on the healthcare system so that you don't just collect them and leave them sitting there. Secondly, it's important that countries identify their need areas so that they can develop specialist programs based on those needs.